Imagine standing in front of a mirror for 4, maybe 5 hours a day. You are cataloging microscopic variations in your skin texture, a fraction of a millimeter of asymmetry in your jawline, or the exact slope of your nose. To anyone else in the room, these details are invisible. To you, they are glaring, inescapable deformities. In a search for relief, many subject themselves to painful dermatological treatments, aggressive orthodontics, and invasive cosmetic surgeries. But the stitches heal, the swelling goes down, and the psychological distress often spikes right back up. The anticipated peace of mind never arrives. These medical procedures fail because they target a physical reflection, missing the underlying psychological condition. Clinicians define this obsessive preoccupation with an imagined or slight physical flaw as body dysmorphic disorder, or BDD. This grid illustrates the scale of the issue among U.S. adults. Out of these figures, 2.4% will light up. That represents millions of individuals navigating their daily lives while carrying this invisible weight. Society often writes off this behavior as extreme vanity, a label that ignores the clinical reality. BDD causes deep psychological pain. It drives people into isolation, impairing their ability to maintain relationships, attend school, or keep a job. Yet it hides in plain sight. Dermatologists, cosmetic surgeons, and even the patients themselves frequently miss the diagnosis for years, assuming the problem is physical. Because the medical community and the sufferers are investigating the wrong target, patients remain completely locked in suffering. This flowchart maps BDD's pathology. It starts with an intrusive thought regarding an unobservable flaw, spiking severe anxiety. To cope, the brain forces safety-seeking behaviors, mirror checking, grooming, or avoiding reflections entirely. This buys momentary relief, but anxiety returns, trapping them in a relentless loop. Consider what happens to this loop when a physical intervention, like a surgical rhinoplasty or cosmetic injections, is introduced. Modifying the body part bypasses the cognitive distortion running the loop inside the brain. The original programming is still active. With the loop intact, the brain goes to work. It magnifies the modified feature, concluding the surgery failed, or latches on to new flaws. Because the underlying perception is the issue, physical modifications are a useless tool for dismantling a psychological trap. Breaking the cycle involves cognitive behavioral therapy, or CBT. A wedge drives into the connection between the distress and the reaction. By targeting and dismantling those specific safety-seeking behaviors, CBT stops the gears of the cycle from turning. This therapy is often paired with SSRI medication, prescribed at higher OCD-level doses, to help quiet the obsessive neurological noise. Relief comes from changing the mind and rewiring distorted thoughts, not from modifying the physical body. Diagnosing and treating this condition requires care from licensed clinicians who recognize the root cause. This map of Georgia illustrates the reach of coping and healing counseling, a specialized telehealth practice offering BDD-informed care across all 159 counties. Their team provides HIPAA-compliant telehealth services. They ensure care is accessible by offering $0 Medicaid copays and accepting major insurances, including Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. People with BDD deserve care that treats the obsessive preoccupation, not the mirror.